Awesome. Thank you guys so much for joining us this evening. We're really honored and appreciating you guys' time this evening. I do have to apologize. I've lost my voice. I'm up in wonderful, rainy Washington, where we just opened up. We just added OT to our current services there. So I'll tell you a little bit more about that. So I do apologize for my scratchy voice, but the voice is just because just how excited we are that we've expanded OT. I just can't stop talking about it. So anyway, but I do want to introduce these wonderful presenters. We have done a presentation for MeBe and for other organizations related to pediatric feeding disorders and how we utilize our collaborative approach in MeBe. So we're really excited to share some important tips and tricks to help you and your family in your home. And what we'll do with these first few slides is just introduce ourselves and introduce MeBe as our organization. So my name is Angela Ochoa. I am the Clinical Director of Occupational Therapy. I have been with MeBe since for the last 2 years now. I joined in 2019. And with that, when I joined, I brought occupational therapy to our current lines of service. So in addition to occupational therapy, we have obviously ABA services and speech and language pathology here. And I'm just so fortunate and so grateful to work among these incredible collaborators and these wonderful clinicians. And we're highlighting certainly those of us this evening that really feel passionate about this particular service area. A slight background on me: I have been an occupational therapist in Southern California, specifically San Diego, for the past 13 years. And I'm excited that we get to share with you all the different things that we do and how OT and speech and ABA can support you and your family in this important topic. So I'll hand it over to Nicole.
Hi, everyone. I'm Nicole Frolander. I am the Senior Regional Director for ABA Services in the Southern California region. I have been in the field of ABA for about 15 years, and I got my first touch of feeding therapy and my experience as I was coming out of undergrad and grad school, and I got to participate in wonderful feeding programs through UC Davis and a collaboration project with Cal State Sacramento. And I have published research in the field. I absolutely love this topic, and it makes me super excited to be able to be here and speak with you all. I've been with MeBe now for almost 3 years, and it's such a pleasure to join you all tonight. Hylan, I'll turn it to you.
Hello, everybody. My name is Hylan Noble, and I'm the Associate Clinical Director of Speech Language Pathology here at MeBe. I have been at MeBe for 3 years. I am originally from Alabama, hence the accent that you will hear. But I have been in San Diego for about 6 years practicing speech language pathology. Prior to that, I worked at Vanderbilt University in their autism center and did a lot of diagnostics and evaluations for kiddos, specifically with autism spectrum disorders. And I also have extensive experience with feeding disorders as well prior to that, working in the NICU and working closely with lots of occupational therapists and some behavioral therapists as well. So I was really excited when MeBe brought on the feeding therapy program, and to be a part of that and helping develop that with our awesome occupational therapy team and ABA team has been truly a pleasure. We love working with all of our kiddos, and we're super excited to have you here with us. Shayna.
Hello there. Hi, I'm Shayna Smith. I'm an occupational therapy assistant here at MeBe. And so I have been working with these ladies for about 1.5 years now. I've been in pediatrics for almost 8 years now, and also working a little bit with adults along the way as well. I started getting into feeding more heavily about 6 years ago with some of the different trainings, and have been working a lot with our ASD population. And so working on a lot of the sensory-based sides of that. And then, joining with MeBe, we've been able to get lots of feedback on the behavioral side, which has been helpful in terms of how to support the families and whatnot. So I'm really excited to be able to go through and combine our two approaches. And so you can see like how valuable collaboration is.
So to give you some background on MeBe, MeBe is about being me. And so what we do in our organization is we integrate research-based strategies with intense personal attention to provide therapy that's engaging, flexible, and customized to your child's needs. We all understand that every child that walks through our doors or into our Zoom chat rooms or however we're providing treatment for them or into their homes, we know that every child is unique. Every family has their own needs and priorities, and we work with you and your child and your family to identify your priorities, work on things that are most important and meaningful to you. And we also utilize research-based practices to provide the services that we provide to you and the family. As we mentioned before, MeBe provides ABA services, occupational therapy, and speech and language therapy. We're very excited to also let you know that we have several locations that MeBe provides services. A lot of us on this call this evening work in San Diego, but we also do provide services in Los Angeles, the Bay Area, and California. As I mentioned before, we do also provide services in Seattle. We have a clinic space there where clients can come in to our center and receive ABA services, speech therapy, and now occupational therapy as of this month. I'm also very happy to say that we have services that are provided in Denver, Colorado. And this month, we're also opening up a center that will have all specialties provided in Phoenix, Arizona. We also have services that we provide in Virginia and several locations in Texas, and soon Georgia and Maryland. So we're very excited that we'll be able to service all of these communities and provide these, you and your family, these services that we provide. If you don't already, please be sure to find us on Instagram and Facebook at MeBe Family. You can find us online at mebefamily.com, and our phone number is listed here. If you have any questions or you'd like to reach out about any of the services that we discussed this evening, as well as any services that you're interested in the future, we are very happy to help you out and get you guys started with us.
Okay, so today's topics, thanks so much, Angela, for that great introduction. What is a feeding disorder? We're going to do a brief review of that. We're going to talk about factors influencing a feeding disorder. So what are some causes of a feeding disorder? And approaches. How do we help your kiddos? And we are going to send you off with some helpful tips. So for those of you that have kids who are having difficulties, we want to give you some tips, especially with the Thanksgiving holiday coming up, of ways that you can work on some of the exposure to a variety of foods and playing with foods. Well, we have kind of a variety of tips for you. Okay, so what is a feeding disorder? Let's dive right in. A feeding disorder is diagnosed when a child is unable or refuses to eat or drink sufficient quantities or varieties of food to sustain weight, meet nutritional needs, and or grow. So there are a range of feeding disorders or problems with feeding that we often see. Total refusal of solids, so solid foods. Adipsia is the lack of thirst, so really not consuming enough liquids or not even really having that desire to. Some of our kiddos are tube dependent, so they have to have feedings through a tube of some sort. Liquid dependence, maybe they only intake foods in that liquid form. They have a limited intake. So maybe they only eat a small portion of foods throughout the day. Selectivity by food type. This is one that we probably see the most often. We see a lot of kids that have difficulty with, trying different textures, different types of foods, different categories of foods. Maybe they only eat crunchy foods. They don't eat anything mushy or soft. Maybe they don't eat any vegetables or any fruits, and they'll only eat carbohydrates. So very selective about the types of food for whatever reason. And then a lack of self-feeding. That's something we work on. So not using the appropriate utensils and tools. There are also other feeding disorders we see, but these are probably the most common, and there's such a wide range. So if at any point you're concerned about your child's feeding, whether it be because they're not growing, they're not consuming enough calories, maybe they're not taking in a variety of foods, it's always a great idea to talk to your pediatrician, bring it to their attention and really describe what you're seeing. Also, I would suggest to get a video of mealtimes as well to show to your pediatrician. But these are just some things that we typically will treat. So research and contributing challenges. So up to 70% of children with ASD exhibit some form of selective eating. That's a huge statistic. So a lot of our kiddos on the autism spectrum have difficulties eating. It may not be because they can't actually chew the foods and swallow the foods and consume them. A lot of times for our kiddos, it's because of that sensitivity, right? So, or it's that selectivity of the food. So having those sensory issues, again, going back to that idea of only consuming foods that are certain textures. So only crunchy foods, or maybe they only want liquids. Leaving out certain food groups. Maybe they only eat chicken nuggets from McDonald's. They only eat mac and cheese that's Velveeta and they can see the box. So very selective. And our goal is to help them get through those difficulties and find some new foods. Research suggests that at least half of all children with autism spectrum disorders have, gastrointestinal symptoms and challenges. We see this a ton with all of our patients. So difficulties going to the restroom, maybe not going to the restroom, reflux, you name it, gastritis. That's pretty common in our kiddos with autism. So something to think about when you're looking at your child and how they consume foods. So there are often some oral motor factors. So feeding is not an innate skill. That's the number one thing I tell families. I think that we tend to think that children just learn how to eat when they're babies and then they carry that skill with them. Once children get past that first 6 to 8 weeks of feeding, they're learning to eat based on what we introduce to them, how we're getting them to latch, and then it goes from there. So it's a learned skill based on the tools that we are able to give them. And that's tricky if our kiddos are selective or they don't have the oral motor skills and they can't coordinate that range of motion, strength, the movements. It's really complex. So feeding requires the ability to coordinate your tongue, your cheek, your lips. All of those different oral motor movements have to coordinate at the same time. It's kind of the same with our speech and language, which is a whole nother kind of soapbox I could get on. But it's super complex, all of those movements moving. It's one of the most complex, motor movements that we have to coordinate as a human being for feeding and for speech and language. So we have to really think about that when we're looking at our children and evaluating them for feeding disorders. So swallowing requires the ability to control the tongue. So you have to control the food. So your tongue is kind of like a boat. You have to control the food in the oral cavity. So you have to be able to close your lips, control the food on your tongue. You have to be able to break down the food, and your tongue has to move it from side to side in your mouth to into the different parts of your teeth. Then you have to push it to the back of your throat, which is your pharynx, and then you have to be able to swallow it. It's a whole process, and our brain has to work together with all of those motor movements. It's very complex. So oral motor skills, chewing, swallowing, your lip seal, closing your lips, cheek movements. Your cheeks have muscles that help us with breaking down foods and moving the foods in our mouth. It's all extremely complex. So things that you want to look for to maybe give you red flags or ideas that your kiddo might have some oral motor difficulties is poor chewing or no chewing at all. Maybe the child puts a food on their tongue and they just swallow it. So I see a lot of kids that here's a blueberry, it's on their tongue, gulp. Here's a piece of pancake, it's on their tongue, gulp, and it's terrifying, right? We've got to chew. So if your child's not chewing and they're just taking things back. Food selectivity by texture. Sometimes our kids are picky about their textures because they don't like the texture, but sometimes it's because it's hard for them to break down. It's hard for them to chew. It's hard for them to move their tongue in certain ways. It's hard for them to push it to the back of their mouth. Therefore, they just avoid that texture altogether. For example, meats or vegetables. That takes more work and it fatigues them. So then they don't want to eat it all. So I'm just going to avoid that food. The inability to advance to age-appropriate food texture and bite size. So it's not always behavioral and refusal. Sometimes it is that lack of ability. So we need to teach them what to do to break down those foods. If we see any coughing, gagging, or vomiting around meal times or when consuming liquids, especially if it's consistently. So of course it's going to happen from time to time with kids, but if you're seeing that consistent pattern, that's a red flag that something is going on with that process of breaking down and swallowing the food, and we need to look at that. Packing foods into mouth and cheeks. So a lot of times we see kids do this where they just shove all the food in their mouth and they hold it in their cheeks, like a little squirrel, right? that's not good, right? It might be kind of cute sometimes to see them do that. And we might tend to think, oh, they're just really hungry. They don't want anyone else to have their food. No, oftentimes our kids do that as a compensatory strategy to push foods down their throat. They will pack foods in to push the food in that they already have because they're not appropriately chewing, moving their tongue the way it should to break down the foods to swallow it. So that's a red flag. Food falling out of their mouth. So if we have a kiddo where there's just food everywhere, obviously this would be, at a certain age, that's a red flag. What's going on? Why is their mouth always open? Why is their jaws flopping around? Why is there food all over the place? Why can't we close their mouth? Oral aversion or hypersensitivity. So kids that are just refuse to have certain things touch their lips, touch their tongue, or when they do, they have a big reaction. They gag, they vomit, or they scream, they holler, they turn away. Those are red flags that something's going on. So oral sensory deficit, so hypersensitivity or hyposensitivity means that maybe they need more foods. That can kind of go back to that overstuffing or packing. Sometimes our kids that are hyposensitive means they're not feeling the textures appropriately, which OT can definitely get into more. They tend to overstuff so they can really feel that crunch and have that sense of the food in their mouth and on their tongue and to feel the temperatures. So these are just some things to think about with oral motor factors as well that could be contributing to your child's feeding issue. Approximately 61% of children with feeding problems have oral motor skill deficits. Again, a large statistic. So these are just some great things to look for when your child is feeding. It's not always just they don't want to try the food. It might be just really tricky for them.
All right, so we wanted to go through and try and add some quick tips and ideas and explain some of the things that we look at right away. And one of the big factors that we look at are both physical and environmental factors. And one area that's really important across the board, any discipline that's working on feeding, is to make sure that we're addressing posture. And so we look at positioning as a big part of it. What you're seeing in the pictures here are kiddos that are kind of set up in both functional and non-functional ways. One of the kiddos has a little booster seat, not able to keep themselves supported. There's nowhere for their feet to go. It's too far back to keep their back up. And so if you have a kid sitting there for more than 15 or 20 minutes, which is what we shoot for like a snack, they're going to fatigue very quickly. So on the bottom, there's been a simple adjustment made where we add something underneath their feet. We scoot them up to the table at the right distance, and then they're able to support themselves more. Just the foot support alone helps them get into a nice upright posture. That's going to keep them attending longer, and it's going to keep them interested in their meal more. And then we also look at some things like how long age-wise do we expect kids to sit? And this kind of varies because it's really interesting. It depends on kids. We really don't want them sitting for these like therapy type meals or at dinner tables. It's not that we don't want them there, but for kids, they lose interest at a certain point. And so more than like 30 minutes, it gets hard for them. If you have a kid that's at the table not finishing their meals within 35, 45 minutes, another big red flag. Kids should not take that long to eat. A lot of times that means they have a hard time with those skills. So we want to make sure the expectations are realistic. Snack time, 15, 20 minutes at the table. Meals, 25 to 30 minutes. And then again, back to that postural piece, do they have the strength and the endurance, the attention to sit for those meals? Because that's going to factor into, when you're presenting these things, can they manage it with their oral motor skills? And then physically, can they stay up and handle it? Is their neck strong enough? That's why when we start with these little tiny guys, they're in certain chairs that give them the ability to recline, because it is hard for them to be up, to both manage the chewing, the swallowing, all of that while they're upright. And as they get bigger, that doesn't always go away. A lot of the kids we see in OT are facing a lot of physical challenges as well for both motor planning and postural core stability. And so this is a big thing that we can do to help them at least have a solid starting spot. So within the space, one thing that we look at as well are sensory factors in the environment itself. So when we are trying to get kids to the table, make them successful, we want to really make sure that we're not making them compete as well with other stuff, or there's not competing stimuli in the environment. So right away, we don't cold turkey kids from these things, but We don't want to necessarily have all of these other items around because it makes it hard for the food to be the main event. So things like the TV, the iPad, their toy box is right next to them, the dogs, the cats, whatever animal is coming up and grabbing things from them, or a family member, they're at the part of the kitchen where somebody's walking in and out over and over, all those kinds of things. It's really distracting. And every time they're trying to eat, they lose interest. They're there longer, and the longer you're there, you lose appetite. So it becomes a challenge. For our guys that have these hypersensitivities, things like smells, lighting, temperature, the noise in the room can cause external stress for their body that makes it really hard for them to sit and attend. So once their body starts getting overloaded, their body starts losing an appetite as well. Stress decreases appetite. So we want to make sure, let's make it a comfy, cozy space. Let's make sure that they feel good there. And that's going to make them more successful overall if they're not feeling bombarded. And then as we progress through this, how is the food presented to kids? You know, it's not essential necessarily to have dividers. You know, there are still adults that have a hard time mixing their food. That doesn't mean, you know, that you can't be successful in eating different foods. Some people don't like to mix. But when we're presenting them to them, you can see one of the plate, like they're very ordered and some of them aren't. The third plate that's on like a little paper plate. I mean, if somebody handed me that, I don't even know half the things that are on the plate. I've worked through picky eating myself as an adult, and I'm like, I don't know if I would feel comfortable about that myself. I fall kind of in the middle. I need like not so many things, some options. So when we're presenting things to kids, are we making them nervous just from how we're giving them the food? So that's going to support them as well. And you can kind of see too, like there's some kiddos that when they're using these distractions in the environment, like the TV or the iPad, they don't actually sometimes realize what they're consuming either. So all of a sudden it's like, well, we've taken that stimuli away and now their appetite has dropped and their interest in food has dropped. It's hard to get them to eat those things. It's because they weren't really paying enough attention to be able to recognize that the next time that food comes up, that's what was happening. So we'll keep going. So one of the things that, these are a lot of the things that we look at, and this is actually both for the sensory-based side and behavioral side of things. And it's really hard to weed these out. This is why we take a collaborative approach, because, you know, one side or the other, the kid might be referred to behavioral therapy first, or they might go into OT first or speech. And so we have to figure out, okay, where is this coming from? There's a lot of times that I, you know, have had kids that I thought were, you know, they come on board because they're gagging and vomiting and all those kinds of things. And it does come from more of a behavioral side. There are behavioral responses, but then we have a huge sensory response to that too. So we really have to weed that out. That's why we have somebody go in and do those. They look at the kids and how it reacts with the environment, the people. But one of the big factors is if they're turning away from the table, they're turning away from you. They don't want to look at what you have to offer them. Whether it's behavioral, whether it's sensory, it's hard. And so we have to figure out how can we make them more successful in that moment. When they're little or big, if they're pushing the item away from you, they're not ready for that to go into their body. And that's a big thing, right? Like feeding is a big thing we can control. There's only, you know, so many things that can really be controlled, but what goes into our body is a huge piece of that. So we want to respect that and give them an autonomy and understand that, like, if they're doing that, okay, what do we need to do to help get there? If they're throwing items, if they're attempting to get up, this is a big complaint that we receive is they won't sit down for meals. A lot of times it can be attention, it can be sensory related that they don't have the regulation skills to be there. So we do a lot of preparatory work, but also if you have set them up with this plate, some of the ones like we had in the last slide, they're going to look at that table and be like, I'm not going there. See ya. They're not coming over. So you want to be able to set them up. I often don't put the food down until the kid is already there, or I help them plate it and carry it over. So we all go over together. If they're crying, whining, tantruming with meals, again, stress equals poor appetite, poor interest, poor success. So we want to work through those things. If they're being aggressive, this does happen. I've definitely had a kid break a high chair. It was literally, I think I brought the bottle out of the fridge, didn't know it was a trigger. Put it away right away. I'll tell you that. It was a really rough time. There's some foods that are so hard that they come out, anxiety sometimes can come out in an aggressive way. I'm afraid of that food. And the only way I can show you is I'm going to hit it out of your hands. I'm going to slap you, whatever, because that means that food's going away. Spitting foods. I definitely don't get as much of that. on the OT side, but every once in a while we do. And that's where we do have to weed out. Is it because they don't like the flavor of it? Or is it because they're looking for attention within those kind of pieces? Expelling food, so basically just pushing it out of their mouth. What's the age appropriate level to that? If they're gagging, gagging, your gag reflex is in the back of your throat. Think like when you swallow water and you cough it up. That's very different than walking into a room and being like, ugh, that's a horrible smell. There's a sensory gag, and then there's an actual physiological gag that happens. So this is a big thing that we look at. If we have kids, again, could be behavioral, could be sensory. If they learn that every time they do that, they can get out of things sometimes, then it might be that. But if that happens when there's certain stimuli in the environment, then we have to go, how can we desensitize their body? How can we support them so that that's not happening? The ones that really get missed though are coughing, blinking, and yawning when kids' sensory systems start to shut down. So these are things to look at for your kiddos. If you see them really starting to dissociate from the meal, that means that we really need to pull back what we're doing to help them be able to come back to the table again another time without associating it with like a really bad time.
Okay, so how do we help them stay at the table? You can use a variety of things. Very commonly, we use visual supports such as schedule and picture routines in which it's lined out on a strip for them. What's coming next? It could be written on a whiteboard. It can be put up on a chalkboard so that they can see that there's something coming after this, that there's an end time to this mealtime or the feeding therapy. And then when you're presenting the food, as Shana was saying, you need to make it manageable. You can't come with a plate of a whole bunch of things and 20 things that they need to try. It's so overwhelming for them. So, I know a lot of parents, they want to get their kids to eat these full plate meals and all of these things. And we want to get you there. And, we just have to make it manageable at first. Otherwise they shut down. They see 30, 50 bites and they're saying, there's no way I can do this, So you start small and you build them up for success and you grow and stretch them in these different areas so that they're able to handle these huge plates of food with 20 different things on them, especially with Thanksgiving coming up, because we're going to see a lot of that, right? Another one that helps a lot is first then language. When you're saying, first, I need you to take a bite of this, or I need you to do this, and then you can have X, Y, or Z. When you lay that out in front of them, then they feel like once there's something to be gained from completing the task, that's a reinforcement, that's a reward. And then it also delineates what is expected of them in a very clear manner that lets them know once you do this, then you can be all done and you can, go on to the next thing. Digital timers, I'm a huge fan. Clocks, kids don't really pay attention to the average clock. A digital timer, man, you see a countdown timer. They are so motivated. You're going to beat the clock, race the clock. I've used digital timers in 1,000 different ways to get kiddos to, get motivated or to at least be able to see how much time is left before this activity is over. Then a big one, decreasing the wait times. Every minute that kiddo sits at the table is time, and everything that you can do to prep and get it all ready for them before they're actually there is going to save you exponential amount of time dealing with behaviors or other things. They, like Shana was saying, they have limited time, like 15, 30 minutes, that their actual bodies are able to handle sitting at that table. So make the most of it. Don't waste it sitting, while you're preparing the food. Call them when it's ready. It will save a lot of tears at the end of the day and make their bodies ready and able to handle what's being presented in front of them in a timely fashion.
If I can jump in real quick, we did get a question.
Mm-hmm.
When you pull back, do you give them a safe food? That question kind of came in also when Shana was talking too. So I think it's just, do you switch them out and give them a safe food?
I think that depends on the kiddo. Shana, I'll let you jump in, and like what you're working on and what you're trying to accomplish, but I'm curious. Go ahead, Shana, I'll let you jump in.
Oh, absolutely. I think this is dependent on what the reaction is from the kids. So again, there's no way to clearly pull away from the fact that it's sensory behavior. They are combined. They don't ever go away from that. But I really have to play it kid by kid. I try to set them up from success and giving them the expectations ahead of time. So when we are teaching these skills, we go from a fundamental side initially. When we're presenting foods, we try to teach them, like, you can place it here ahead of time. You can push it away from you if you need it away from you, so that they have the skills. That doesn't happen though when they're little, or maybe their cognitive level isn't there yet. So when that happens, if I remove the item, I will a lot of times see like what I have to see a reaction to. Like, I'll see, is this the first time I've removed it? If so, am I able to represent it? That's always the first thing I'll ask myself, is like, what was the reaction and why was that? Was it right when I put it down? Those kinds of things. Or was it all of a sudden they tell me I'm done with it? Are they full? Did they lose interest in that food? Did you hand them an entire bowl of oatmeal and they're like, I'm done with this. I don't want any more of it. I'm overwhelmed with that flavor and texture. I'm finished. I'm all done. What I don't try to do though, is that exchange of like, I don't want this, I want that. Because what happens sometimes is like, they do learn, like, every time I don't want a food, I push this away and I get what I want. So it's a balance. I go in with a safe food a lot of times from the beginning, and then I'll introduce like a novel food, or I'll bring the novel food onto the same plate and see if I can tolerate it there first, things like that. But I try not to like right away do that. I always have safe foods within the meals. I never have an entire meal of challenge foods. That's definitely not something we do. That's an entire meal of stress. So it depends on the kid. I have had this happen lots of times, where even just having it on the side table is too much. If I reach for it, they'll start screaming, they'll start yelling, and I'm like, then we're not ready. Maybe I bring it out from a different container at that point. Especially if, there's family norms that like those foods are around all the time. So it really depends on the kid, but we try to desensitize them to the presence of the food, however far that has to happen. And maybe changes need to go through that. Like, it's a different kind of ketchup. It's a different kind of maple syrup. It's whatever. It's a different package of Eggo waffles, so that they're not having that trigger based reaction first, because you're not going to typically be successful. And then making it safe. So the biggest thing is like, I have my safe food, and then the food that's been introduced to me is coming in tiny, tiny bits, so that that's safe too. It doesn't feel scary. But yeah, no, I typically don't try to offer something right away, because they will often have that reaction of like, I'll just yell then, and I'll get the bad food away, and then I get the good food here.
I was gonna add in too, having a safe food is just always good. Like, even that's just a must. So I try not to do a tit for tat, right? Where you have this and this, and then this, and then this, right? The kiddos need to know that they've got foods that they like, that they can consume, that are there. And that helps so much. So I agree with that, Shane. I just wanted to throw that in. I think having those preferred foods is a must, especially during meal times versus therapy meal times, which I know we have some information about too later on.
And we'll kind of talk about this later, but one of the things is we might not offer an entire serving of chicken nuggets if that's their favorite thing. We might offer one or two so they don't fill their whole belly up, and then start working into these harder, challenging foods. So that's the thing is, we can always come back to their food. We can always add more into their meal, but we don't want it to be like, here, you just ate 3 slices of pizza. Let's learn about broccoli. That's not going to work for anybody. So, we'll talk about that a little bit more, but yeah, thank you for asking that question.
All right. So very commonly we hear, my kid's a picky eater. And then we have, what is a problem eater? What discerns each category, and what does that look like? So picky eaters have a decreased range of variety. They consume 30 or more foods. They might have foods that they've lost due to burnout, but they don't fade out for months at a time. It might be for a few weeks, but you're not going to see your kiddo, say, eat pancakes, a couple times a week, and then all of a sudden never eat pancakes again and not want to touch them for the next year. The picky eater will accept new foods on a plate. They can usually touch them or taste them. It doesn't freak them out. You're not going to see a huge behavioral meltdown because the slice of meat is anywhere on the table with the rest of my food. So that's definitely something that, will discern them. Picky eaters consume at least one food from all the food groups, and the textures vary. So as Highland was saying earlier, super common where you'll be like, what does your kiddo eat? He eats chicken nuggets, French fries, Lay's potato chips, whatever that may be. It's a variety of very carbohydrate or crunchy based things, or a very certain category of things. And so picky eaters will still eat from all those different categories, maybe not a ton of things from them, but they still eat from most of them. New foods are added after multiple exposures. So say Johnny doesn't like cantaloupe, you can give it to him, play with it. After a couple times, Johnny is okay with the cantaloupe and he's going to eat it. Whereas some other kids, like you could present it 100 times, you're not going to get a different response other than, you know, whatever behavioral or other reactions they're having, whether that be sensory or motorly based. Problem eaters, very, very different. They have a restricted range and variety, usually less than 20 foods for sure. Foods, once you lose them, they don't come back. You'll be so often, you know, they love strawberries for so long. It's their most favorite food. They won't come anywhere near them now. You know, things like that, you'll see just completely drop off, where it might have been their most favorite thing ever. They ate it every day for months and months and months, and then never again. Then you'll see the problem behaviors that we, you know, have mentioned during interjection with new foods, you know, whether that be walking away or, you know, the entire list of things, behaviors, the crying, the tantrums, just even pushing it away or verbally protesting that, that will come with anything pretty much new, because it's very terrifying to them. It's out of their domain, out of their comfort zone, and it's unfamiliar to them. So another thing that we'll see is after you get in there, you could see that after maybe 25 attempts, like serious feeding therapy, like representation and getting it, then, you know, they might add a new food to their thing, but it doesn't come like once or twice, like say the picky eater would have. They are also inflexible about the format of certain foods. And this goes to speak for the, I need my apple juice in this box in this container. I only eat McDonald's fries. I have to have chicken nuggets from Chick-fil-A. It needs to come in this box, in this size, in this form. It needs to be on this color plate divided into this 3 sections. It needs to be this temperature. there's, or, you know, this, there's so many different things that they can delegate as like what they prefer and how that's presented to them. And then another, I skipped through it, but it refuses the entire group of foods, or foods of a certain texture. Anything mushy, no mashed potatoes, no, you go on a list for days of mushy foods, no yogurts, no anything, you know, or they could be the exact opposite, no crunchy foods. Like, I don't like apples, I don't like carrots, I only like the mushy foods. And then you have the in-betweens, but they're definitely a preference for a specific texture or a food group category. So that's another one that we'll definitely see in that problem eater category. Okay, this next slide is about the interaction of all the contributing factors that play into peace. So as the girls were saying, and as we know, there are so many factors that play into feeding. It's not just the food. I don't like it. I don't like the way it smells. It's so many different pieces that they are tackling to try to accomplish the task of eating, and then eating something they might not like, not the texture they like, and so much more. So feeding disorders are typically developed and maintained by this interaction of the multiple factors with the problems, and they often develop as a result of medical and the oral motor factors. What may start as a refusal because of a medical condition or an oral motor delay may also become to learned behavior. So as Shana was saying, like that gagging, you know, oh, they learned mom puts the mashed potatoes on the table. I hate those. I'm just going to gag. I get out of them. I don't have to eat it. That would be a great example of a learned behavior. So we have all 3 of these components working together. And then unfortunately, this may result in a vicious cycle because the problem behaviors are getting reinforced by getting out of these things, which increases the likelihood that they're going to do it again. It's like, hey, it worked for me once. Like, I'm going to try it again. Why not? I don't like that. And I don't like that either. And then they apply it to a lot of different things in their food repertoire. So for a child who already has these oral motor skill deficits, missed meals also results in the delayed skills because they're not getting the practice they need to chew and use all of those wonderful features in their mouth, because they're just like, whatever, I'm skipping out, like I'm good, and it's like opting out of the gym. They need to, at that little age and time where they have to strengthen those muscles and they have to practice. It's like any skill that we're doing in life, you have to practice to get good at it. So while all these medical and oral motor factors play an important role in the feeding disorders, they place them at a higher risk now for even developing a feeding disorder, which is why we develop all these interventions based on the interdisciplinary range. I've worked in doing feeding therapy where it's just ABA, and it's very different than what this global approach is, where all different disciplines are in there, because I can be a PhD in all, ABA, but I don't have a piece of what Angela knows or what Hyland knows or what Shayna knows. And they contribute so much more knowledge and a skill set to be able to actually tackle these very, very complex feeding issues that these kiddos are going through.
Okay, so the multidisciplinary approach, just like Nicole said, is huge. Having the eyes of a speech therapist, an occupational therapist, and an ABA therapist is huge, because there is usually not one specific thing that is causing all of these feeding issues, right? It's all these contributing factors. That's why feeding disorders are so complex. So speech, typically on a multidisciplinary team, is going to look at the oral motor skills and really assessing those skills, addressing safe eating and food progression. So safe eating and chewing and swallowing and helping kiddos develop those skills. So the tongue movements, the lip movements, the jaw movements, whatever we need to do to safely consume the food. The ABA team is going to assess via caregiver interview and mealtime observation. So they also may conduct a functional analysis, which Nicole could dive more into, to determine the functions of the behavior. So what is actually happening before the behavior? What's potentially causing this behavior? What are the other contributing factors? Like Nicole said, the medical factors, the oral motor factors that are resulting in this, behavior that we're getting, the refusal of the food. The occupational therapists are going to assess the oral sensory skills. So kind of like I mentioned before, that sensation, maybe hypersensitive, hyposensitive, what's going on with the processing of that information, processing the sensory information. So how is the kid visually looking at the foods, processing that, the smells, the textures, and feeding versus eating skills. So we actually have a lot of overlap as well. It's really great that we all have separate training and separate expertise, but at the same time, we all have a lot of similar training and how we want to approach these skills. So we all might come at it from a different perspective, but at the end of the day, we collaborate and we utilize our own unique perspectives to support the growth with the child and family. So I have a lot of kiddos that I work with at the MeBe Learning Center that I will have an OT come in and look at, or I might have an ABA come in and consult, depending on what I'm seeing, and say, hey, what's going on? What kind of tips do you have? What do you think? Am I on the right path? That's what's great about having that multidisciplinary approach. Again, we all have different backgrounds, but we utilize those skills to do the best that we can to help with those optimal outcomes.
All right. So in terms of looking at these different things, we look at a lot of different pieces. Feeding is super complex, as we've kind of just been talking about over and over. And we want to get intake information from the family, especially whoever the caregivers are, about what mealtime looks like, what foods they're actually eating, their medical background. We want to know all the pieces that go into who this kid is beforehand and the family dynamics. We also need to see what's going on. So we need to observe a snack or a mealtime so that we get an idea. I can't tell you how many times I've thought things were fine, and then all of a sudden I realized the kid never actually sits at the table. They just walk around being offered the food, and that's really hard because they're not paying attention. We'll also do an oral motor assessment. So that's where that collaboration piece comes in, is making sure that that kid can safely manage the foods. What muscles are their weak muscles? Are there tongue tie issues? All those different pieces. And then we go through and try and get a preference assessment on what foods they're eating, all the way down, like through all categories of different foods. If it's texture, if it's color, if it's types of foods, and then also a background of things that they maybe ate before and things that have been eliminated now, anything that's changed in terms of that and how long that's been going on for as well. And then in the oral motor components, Highland touched on this a little bit in terms of the level of coordination required, but in the mouth, we do have kids that are impacted physically, like their bodies are not able to manage this because their mouth is not set up that way. So we are looking at things like their palate, how high or how flat is that, how flat it is. Do they have tongue ties or lip ties that restrict their ability to move foods within their mouth? That their lip, tongue, and cheek strength, or that they're too tight. So can they actually, are they low tone? Are they able to form that pucker to be able to manage the food when they're swallowing? Or is it so tight that they can't get their lips over the food to close? Is that why things are falling out? How about their teeth? Are their teeth able to line up in the back? Are they missing teeth? When they're trying to manage foods, like things like tonsils and adenoids make it really hard to manage some of those sticky foods. So this goes into a whole other like medical background with kids, but for them, I see a lot of our kids have issues with those real sticky foods. You'll see that they fatigue quickly because it's hard to breathe. It's hard to swallow. It gets stuck back there, and you'll see them compensate by doing things like drinking lots of fluids, even because they just can't handle all those foods. They might like the flavor, but it's hard. And then managing textures too. So we'll go through and look at this. This is definitely sometimes where I'll ask for speech too, because even if we don't do in-house formal swallow assessments in terms of, using diagnostic imagery and things like that, we have to refer out for those type of things. But we will see, like, are they coughing with liquids? Are they coughing with purees? All these things, are they able to manage that? Because that really matters. They may eliminate food groups because they don't feel safe. They're worried about aspirating. We look at how they're chewing. Have they progressed through from munching, going to a diagonal chew, and then rotary, where we're moving the foods across, back and forth. We chew a little here, our tongue moves it to the other side and back. And then the coordination between all of those things. So really, is the kid a really clean eater? Are they a messy eater? And are they managing all the things? We were going to refer out to specialists as needed. So people like dentistry. There are times when kids need teeth either pulled, or we have to look at, like, how can we compensate these kids? Teeth aren't lined up. ENTs, that's where the adenoids, tonsils, even for the ears too, come into play. And then dietitians and nutritionists along the way as well, to find out why these kids are restricting, because there can be those GI issues that are causing them. They know, I eat a food, I don't feel good, I don't want that food. We think that they're just avoiding it, but the body is in tune with those kinds of things. So we want to make sure we're paying attention to that as well. And that's why we ask, like, did that food go away all of a sudden? Or is this something that's progressively happening? Is there groups of foods? It's really important that we look at all of these facets.
I'm just going to jump in here and add a little bit more. My apologies for my voice again. I do know that there are some questions coming in the chat, and we're going to definitely get to those specific questions in our Q&A section. So we're going to make sure we have time. A big portion of this presentation is also tips and tricks. The reason we value these kind of introductory slides, especially these last two, is really talking about the complexities of feeding and eating, and recognizing that while every one of us on this panel have a lot of experience in working with children, or children like your children, that may have present with pretty profound feeding and eating delays, it's really important to know that it's not just us. We do have to refer out. We want to make sure that you have the other tools to fill that puzzle of treatment for you. So exactly that, like, kind of just piggybacking on this, we have additional tips and tricks, and I want to make sure we get to that too. So maybe what we'll do is we'll kind of make our way there a little bit faster, because it looks like we've got lots of questions related to this. So I just want to make sure of that, and it's coming. That's what the next several slides are coming. But I wanted to make sure that we really made sure we touch on the fact that it's not just the therapy. It also, you really have to highlight the medical piece, because the only way a lot of children are going to have successes is we make sure that we address those things too. And it's a collaborative effort on that side. Even the people that don't work for MeBe, we still want to make sure that we're referring to physicians and the other important people on the team.
All right, so let's talk about some behavioral environmental factors that play into things that we see that go on during these meal times and food exposures, new foods. So as a result, we'll see common caregiver responses. Your kiddos doesn't want to eat X, Y, or Z. Say, okay, we're gonna just take a break, or you can come back and finish it later, or just completely in the meal. All right, you don't have to finish it, it's cool, you're good, like we're done. Another thing that parents constantly do with the comfort or encourage or coax the child to stay at the table, or it's okay, eat this food, it's not that bad, and try to work them through that. Another instances, they will offer foods the child will eat. So it's like, okay, you don't want this, no problem, you can have this, which reinforces the bad behaviors of protecting the originals. And then you'll see lots of distraction with toys. So iPads, anything digital on the table, or other things, fidgets, you name it, trains. I've seen a whole bunch of things on a table during mealtime to keep a kiddo busy, to distract them, to take their minds off of like what they're eating or what they're doing or how long they have to sit. So these are all things that we'll see. And unfortunately, most of these things unintentionally reinforce those inappropriate mealtime behaviors, and then they contribute more to the maintenance of the feeding problem overall. So the next part is the treatment part. So to get started, having structured meals in stacks. I can't say enough about this. Structure is huge, and meals should occur at a table in an appropriate seating arrangement. I have labeled my little kiddos that go around and grab food. I call them drive-by eaters. They go by and they walk by and they grab a snack and they disappear, and they go by and they grab a bite and then they disappear. And this kiddo could be eating a meal for what could be an hour, because it's just always snack time. Like I'm always cruising by and grabbing pieces of food. So having that very set place and expectation for them, like we're going to sit down and we're going to eat, and the timer, whatever that may be, to show them the visual schedule, how long it's going to take or what the expectation is. Then target the behavior of sitting for short periods of time and gradually increase it. Do not expect that your kiddo is going to sit down at the table for 10, 15, 20 minutes if they're a drive-by eater. Like 30 seconds, 1 minute, cool, that's a win to start. Like, let's just work on getting sat down and feeling comfortable and safe and not feeling like I'm trapped and I'm stuck in this place and I can't get out and they're going to give me these foods that I don't want. So I think, setting that expectation that it's not going to be forever, because they really do want to get out and escape from that scenario in a lot of times. So, and then that goes into the conditioning the table and chair. So you can't expect them to want to sit in a high chair in which they've been presented a whole bunch of things they hate, and they're stuck there, locked in there, and they can't get out, for however long till mom comes along unlimitedly. So make sure that you're pairing these sitting at the tables with some preferred things, not so much that it's distracting them or that it's completely, taking away from the mealtime experience, but something that's preferred. As Highland was saying, or any other ladies, those safe foods, you need something that they like, whether that's like my go-to, like some kids are like, oh, I live and die for French fries. Cool. Like, well, or whatever that may be for them, that's their comfort item. I've seen kiddos come in with blankets. I've seen them come in with their favorite cars. It can range in so many varieties. It doesn't have to necessarily be food related or, a specific reinforcer, but there's all kinds of cool things that you can bring to that table to make it not so aversive and not such a horrible place to have to be stuck at, is it? Because in their mind, that's the last place they want to be. They're like, I'm cruising around. Like, why do I want to be here? So on the ABA side, we use a lot of consequence-based intervention. So as a multi-component treatment package, we utilize both the antecedent and consequent-based intervention. So antecedent things are the things you're going to do before to set it up for success. And the consequent-based things are the things that you're going to do afterwards, after the behavior happens or whatever is going on during that session. So demand fading is one of those things where you're going to slowly decrease the level of the demands that you're placing on them. Simultaneous presentation is when you're going to prepare two things. Here's your green beans, and here's this. Which would you prefer? And let them make the choice. Stimulus fading occurs in a lot of different ways, in the sense that you can be fading the stimulus of a texture in ABA, you know, in our world. There's also fading of maybe the amount of stimuli or things that are present in the area. Say I've had kiddos that like will only eat with this video on in this place, and then you slowly start to work to fade out that screen time or that activity. So there's a lot of different types of stimuli that are present for them in this feeding environment. It could be a lot of things that you're trying to like slowly decrease so they can focus more on the task at hand, which is eating. Then high probability instructional sequence. This is a great technique. You can get them motivated by doing things that you know they're going to do first before you present the thing that you know they're not going to want to do. It creates this energy within them, like, let's go play. You can play and you can have fun and you can jump around and blow bubbles and do all these things and say, okay, let's go sit down. And they're in a different state and place because they've already complied to a couple series of things that they actually like to do. Therefore, they're more willing to sit down and actually do something that might not be as preferred, but they will. Then escape extinction. This is something that we use probably towards the end of feeding, like as a last resort. I'd like to say it's not always something that you'll see in feeding therapy, because non-removal of the spoon or not being able to leave an area, basically those things are requiring the child to complete a bite or to finish something before they're able to get up. And sometimes kiddos aren't ready for that at the beginning. They are okay with a looser environment. Typically, I will put those types of treatments in where to have somebody physically guide you and touch you, it's aversive. It's not something, nobody wants that at first. And so we will always try with the least intrusive therapy before we go to more intrusive therapies, such as the non-removal of a spoon, in which, there's more contingencies in which they have to do X, Y, or Z in order to be able to be done with that feeding exposure. Something I'm a big fan of is what's called differential reinforcement of alternative behavior. It sounds like a huge, big, very wordy thing, but in reality, what you're doing is you're giving them praise, rewards, something preferred for doing anything else other than the unpreferred behavior or the problem behavior that you'll see around the feeding therapy. And it works like a charm. So all of these things are different things that we'll put into a package based on the kiddo and where they're at and how intensive their feeding disorder is. You might have a kiddo on a G-tube that has never eaten a drop of food like through their mouth a day in their life. And that's going to be very, very different looking than what you're going to do with a kiddo that doesn't like crunchy food. So that's, I definitely would say, is one of the greatest things of this multidisciplinary approach, is because there are pieces of all of our disciplines that can tackle any spectrum of a feeding disorder.
So here we are talking about how do we get kiddos to eat the foods we want them to eat. Recognizing that the children that we see and the children that you likely have in your home are eating foods that are not the foods that are nutritionally valuable. You want them to eat carrots, you want them to eat vegetables, you want them to eat fruits, you want them to eat proteins. And their preferred foods are exactly what everyone else has been saying, and I'm sure you're experiencing, are French fries and goldfish crackers and other types of foods that may not pack a real punch as far as nutrition goes. A lot of times the reasons why children that we see, and it's not specific to a specific diagnosis, the reason they choose these foods is because they're consistent. Every time I open the bag of goldfish crackers and I reach for any cracker in there, it tastes the same, it crunches the same, it feels the same in my mouth, it has the same kind of flavor, it's not super messy on my fingers so I can eat it on the go. These foods tend to be very consistent. Whereas kind of like when we're talking about some of the other vegetables or the fruits that we really want our kids to eat, they vary greatly. Blueberries, for example, sometimes blueberries are big, sometimes they're small, sometimes they're firm, sometimes they're smushy, sometimes they're tart, sometimes they're sweet, sometimes they're bitter. That variability is really tough for our kiddos who have a hard time with expanding their food repertoire. What we look to do as clinicians is expand on what they're eating, but in manageable ways. So we don't jump from goldfish crackers to carrots. We're going to take some steps in between. And the reason we do that is because we want kids to be successful. The more successful they are, the more willing they are to expand their meal repertoire. But sometimes finding those bridges to the foods that we want them to eat is tricky. And so some of our approaches might be something like food chaining, which is what this is an example of today. So let's give the example of our kiddos that want to eat goldfish crackers. Food chaining is the idea that you're going to take one element of the food that they're currently eating and keep that a constant while you're switching to new foods. So obviously here we have a lot of orange foods in our pictures. So goldfish crackers are orange. What else is orange? Cheetos, right? So if we move from goldfish crackers to Cheetos, now, oops, sorry, I went to the wrong one. The reason we might move to Cheetos is because they eventually, if our goal food is carrots, Cheetos look a lot more similar to carrots than goldfish do. So what we try and do is find that element of food and then bridge it to the next food. Now, the reason we might switch to Cheetos first for a child is because Cheetos are really dusty. So they're very different than goldfish crackers to some of the children we see. They're dusty, they crunch differently, they're much bolder of a flavor. They do vary in shape. They're not as consistent as goldfish. They have a different look to them, sometimes there are things, if you've opened a bag and then closed it, they might get stale or get a little bit mushier. So there's variability enough, which makes it why children have such a hard time varying from different ways that food's presented. So by increasing the demand for the child moving from goldfish to Cheetos, it's manageable enough, but it's also different enough that we can continue this path. Maybe the next path is now we're going to keep that stick-like picture of a Cheeto, but we're going to move to maybe something like a sweet potato fry. Now, sweet potato fries are orange. They're similar to French fries if they eat French fries, but they're a little different. They also taste different. They're sweeter. They could be a little bit softer. They could be a little bit harder depending on how it's cooked. They're not readily available in fast food restaurants, so children may not be experiencing or have ever been exposed to something like this. So that's another bridge. But again, it's that orange color, it's that stick shape, it's salty, it has enough characteristics of their preferred food to allow them that success if they're ready for it. Then ultimately, if our goal is to move to carrots, what if we tried carrot chips? Carrot chips are carrots. They're just prepared in such a way that's like chips. So now they look like carrots, but they have that familiar crunch. They have that familiar texture. They have a different flavor, but it might just be enough that they can tolerate it because it's familiar enough for them. Again, if we're successful with one, let's bridge to the next. And then if they're successful with that next one, then let's bridge to the third. Ultimately, with our goal being carrots, okay? This path to healthier foods is widely ranging depending upon the needs of your child and their successes along the way. because you might, kind of to Shayna's point earlier when she was talking about how you might be, your demands might be too high, that your child is overwhelmed or overstimulated and it has a tendency to shut down or avoid the task altogether. Then we might need to use this path that we've created as a way to, as an additional way to back off. If sweet potato fries was too hard, we're going to go back to Cheetos. If Cheetos was too hard, maybe we don't go back to goldfish crackers, but we tried Cheez-Its or something like that. The idea is we want to change it enough where we can continue that success. Mealtime should not be stressful, but very, very often it is. And we recognize that the ultimate goal is we want them to eat this food, but it's unreasonable to expect that your child is going to go from goldfish crackers to carrots in a matter of a moment, because it's too different from the food that they're familiar with. Another thing to consider too is that a lot of times when we talk about this progression of foods, we're looking at it we're basing it on the child's response. So one day a kiddo might be willing to try carrot chips. Another day that might not be the case. I know a lot of questions that we've gotten also in the chat box are related to how frequently we have to present foods in a way that's going to allow kids to be comfortable and successful to progress. A lot of that is heavily dependent on their response, and it's dependent over time. So if they like it on Monday, but they hate it on Tuesday, and then they're fine Thursday, Wednesday, or Thursday, Friday, Saturday, whatever, then what's important there is that on the whole, they're doing well. They're progressing through foods consistently enough. So I think there is data, and it depends on where you get it from, but it can range anywhere between 15 times to present one food to maybe 40 times. It's heavily dependent on the child's response, and it's really hard for us to always give that number. But what's important for us is the consistency. Every day we should be trying these new foods. That's stressful in and of itself. And so as clinicians, what we also try to determine is how can we set you up for success in your home? So if the mealtime meal needs to be different than the challenging meal, we start there. The ultimate thing that's important is that your child receives nutrition and they consume food in a safe manner. That's mealtime. If we're introducing foods that makes them leave the table or they no longer want to eat by mouth, that's a challenge. So we try and separate early on the difference between your meal at home and your therapy meal. Therapy meals are a great way to practice foods without the pressure of intake and nutrition. If we're trying new foods, we might try it at snack time. We're going to try it during our picnic that we make in the living room as a fun opportunity to explore foods. But it doesn't necessarily have to be at your meal time every time. If what happens when you present foods, your child runs away or is avoidant altogether. Our goal is exposure and progression. And sometimes that doesn't include the amount of food that's going in their mouth. We know that that's the ultimate goal. And that path is very different for every child that we see. And what's most important for us is for them to be successful and to maintain those skills. What happens a lot of times if we push kids too fast or if they move too quickly through these steps, sometimes they don't necessarily create that really beautiful foundation of consistent and independent exploration of foods. Because ultimately we want everyone to be consistent and independent in their own way as they progress and get older. So this is one way that we can bridge from the foods that your child is eating to the foods we want them to eat. Additionally, on the same idea, we know Thanksgiving's coming up, okay? So we talked a little bit about food changing the food slightly to add to another food. One way, additionally, what your child may need to experience is something like exposure to the foods in general. So maybe where your child is right now is everybody at the table or the parents are eating their own meal and your child is eating a very limited diet. That's where we start. If we were to jump to now they're going to eat all of these different foods they've never had before on one plate presented in a specific way, you're not going to have the same level of success. We want them to, but we have to recognize that children take time to go through these steps. A lot of these steps are based in development and research when it comes to that sort of thing. So we want to follow their lead. So one way that we can approach this is if your child is currently only eating foods that they want to eat and not willing to try new foods, Instead of choosing the entirety of Thanksgiving meal to be your goal, maybe we just choose one food. Let's isolate one food that you will have during Thanksgiving and make that your goal food. So if we want gravy on the mashed potatoes, they'll eat mashed potatoes with no gravy. Great. Our goal food is gravy. If we want them to eat cranberry sauce, that's very different. Okay, our goal food is cranberry sauce, turkey, whatever that's being presented that's meaningful and important to you and your family. Let's choose that one food to address. If we can get success with that one food, and that depends on your child's response to exploration of that food. If we can get your child to explore just that one food, their willingness to expand the repertoire is much greater because we've already established the pathway for success with just that one food. What we can do at that time then is we can decide, okay, now we have all the foods available, but they're all in their own containers. So as the foods are available on the plate, now you can decide, do you want mashed potatoes? You can scoop that onto your plate, giving a little bit more ownership to them and allowing them exposure to the foods, but on their own terms. We know that's not exceptionally the goal. And a lot of times kids, when they're presented with foods this way, they go for the rolls, they go for the mashed potatoes, and that's probably it. However, that what they're also being exposed to, even if that food doesn't make itself onto their plate, they're seeing their parents, they're seeing their siblings, they're seeing their cousins, they're seeing family friends engage with these foods. Oftentimes, just observing other people is enough for a success in that moment. Being present at the Thanksgiving dinner table, even if they don't eat the food that's being presented, just sitting there and tolerating it is success enough. And that's what we want, is we want these traditions and these routines and these really meaningful, important parts of your life to be integrated, but at the pace by which your child can be successful. So oftentimes just watching their family members consume the foods without them consuming, for me, is a huge win. And I think that we find that the more exposure, the more likely they are to try the food. The more they try the food, the more likely they are to chew the food, and so on and so forth. Then maybe the next goal is, after the food's been presented at the dinner table, then maybe we can have food on a plate. But let's not forget that food cannot touch. I loved this graphic. The perfect Thanksgiving dinner plate doesn't exist. Oh, some people hate when their food touches. Our kids are the same way. It's really important for us that if we give them the opportunities to explore these foods, they need to know that they have the safety and the comfortability for their food not to touch. Sometimes food touching other foods completely or eliminates their willingness to try foods. It's like kids that want to eat sandwiches, but they want to take the bread off, then they want to eat the turkey, then they want to eat the cheese. This is the same thing. But what we can do is provide them into a safe space where if you only want to eat one of these foods, you don't have to eat all of them with all the flavors and the textures mixing. Ultimately, we want your child to have a plate that looks as vibrant and as beautiful as this one. We want the different textures of the turkey on the plate. We want the mashed potatoes to run into the green beans. We want the stuffing to overflow. If this is important to you, this is what we want for your child. But it takes those steps and it takes those opportunities to, let's start small, knowing that our end result will be much bigger. And sometimes it can be really stressful during the holidays, but our goal is, if we can tackle one of these things, we've had a lot of success. And what we find as a whole for our children that we see is they want to be successful, but they don't know how, or the way that they've learned to be successful isn't a way that they can generalize to other skills. That's our jobs. That's what we want to do, is we want to give you guys the tools that you need to help your child progress through these different foods. Shannon, do you want to take this one?
Okay. All right. So we're going to go through some different interventions that we kind of use, but these are things that you can do at home too for exposure. So I saw a question in there about kiddos that are G-tube fed, and that's definitely something that we get in the wheelhouse of dealing with, because that's a really hard area of kids. And, that's a big range. Obviously, we have kids that we see that have either always been on a G-tube from NICU and on, and then are at the point medically that they can transition off. And then we have kids that have had to go to a G-tube because at the end of the day, nutritional needs and health are the #1 priority. So the worst, we obviously, that's the spot where we're going to try everything else before that, but we want our kids to survive no matter what. So these are some of the activities you're seeing here. Are food activities that are out away from the table, maybe, or you're maybe sitting at a table, but they take away the expectation of eating food. So you're getting lots of exposure through texture, through smell, through visual interactions, through the sound of the crunchy textures moving across each other, temperature changes between the dry to the cold to the mushy and all of that. It all feels different. It smells different. And when we eliminate the spoon at the table, sometimes that really takes away the expectation that this has to go in my mouth. So we might, like that middle picture has spoons there for scooping, but we could use anything for that. If that's too much, if that feels like something that's challenging, like they use that at their meal times and you put that there and that becomes aversive, you can use something else, use little tiny cups for those kinds of things. The goal ultimately, and I've just kind of had this come up, I have a kiddo, piggybacking on what Angela was talking about, I had a parent whose goal was, I want to normalize Thanksgiving. I want to make it a fun experience for this kid. So when she mentioned it, I was so grateful that she mentioned it like 4 weeks ago, because we still have 3 weeks until Thanksgiving, because I can't tell you, we hear this all the time, like, Thanksgiving's around the corner. I'm not saying you can't do anything before then, because you absolutely can. You can start making it more comfortable to be around mashed potatoes if mushy textures are hard to see. If that's what you're worried, if that's what the hard thing is for the kid, let's start doing these type of sensory plays. Let's have them help with prepping these type of foods and exploring them beforehand, so that when they come to sit at the table, they aren't screaming, they aren't yelling. So this could be all aged kids, they may be way more willing to explore a wet texture like SpaghettiOs when there's their little trucks present. And so the goal is, if they decide, our little guys especially, we have a lot of kids that mouth stuff. This is another chance too. If we have kids that are mouthing a lot, we can get that sensory play. If they accidentally get some, gooey stuff in their mouth, it's not going to hurt them either. It's not dangerous. And maybe all of the foods in these aren't the goal, right? Like the bottom right-hand corner, there's a lot happening there. There's a lot in there. That's meant to give lots of opportunities for imaginary play. This is a really fun one. I feel like speech really rocks this house with their imaginary play with food. Nikki's told me about some of the things she does, our director, and she's great like that. I take ideas from that too, because the kids, when they get to talk about the food in a different way that isn't about going into their mouth, they'll touch it, they'll smell it, they'll take that dino and they'll eat some of the top of the trees off. They'll dip their little tiny Plagiosaurus into the water over there, whatever. I think that's what he is, and so they'll get more exposure with things that you present them other ways. It's a no-go. So there's a lot of different ways to do this. Something like carrot peels are so simple. You could do that with so many different kinds of vegetables. I love spiralizers, those things that make all of the different veggies and things. You can make that with sweet potatoes. You can make it with different kinds of melon. It's like endless, and it looks fun and silly, but it's safe for the kids. If they eat it, nothing's going to happen. And they're getting lots of exposure in the meantime.
Just to add a little bit more to that too, is that ultimately we know that we want children to eat the food. Our goal, every single person on this panel wants your child to eat the food, put it in their mouth, chew it up and swallow it, and then continue to the next bite. If your child is already being presented with foods and they're not even touching it, they're running away, they're screaming, they're crying, all of the other things we've discussed, or they're avoidant altogether for a variety of other reasons. Exposure to foods allows for additional opportunities to play with that food. Exactly what Sheena was saying. 1 minute you're playing with the dinosaur, the next minute that dinosaur touches your lips, the next minute, and so on and so forth. If the child isn't engaged with the food, then they won't eat the food. So we need to find a way to buy in. They need to buy into what we want them to do, with the goal that we need to progress them to the next steps.
And on that too, like with any of these foods, it's okay to say, like, we can hop over and the veggies that we have in this little melted piece, that can come onto the table at another time, but now they've seen it. So you could introduce it in a little side bowl later on during the day or later on during the week. And now I've seen the veggies, I've seen the green beans, I've seen the carrots. So it's never the goal of just to always touch the foods, but we want to decrease the stress, decrease the maladaptive response, so that we can get them, at least get the food in front of them. That's always the goal, because you can't get it in their mouth if they won't even sit next to it.
So just to touch on this, we think about what is motivating to a child. play, right? That's a child's only job, is to play and to have fun. So what if we made the food like a toy? That's very counterintuitive to us as adults, though, right? Especially the way that we grew up and we were raised. Don't play with your food. Don't make a mess. That's the opposite of really what we want our brains to think about with our kids that have feeding problems. Make a mess. Get the food all over you. We can throw you in the tub, right? We can wipe you down later. The food is a toy. The food should be fun. The food should be motivating. You should be excited to get to that table because you know you're going to try and do some fun things with food. Now, does that mean that we want to teach our kids to do, all of these horrible things with food so that they go to a restaurant and they're throwing it everywhere? No, right? We're going to set some boundaries, but especially our kiddos that have these sensory issues, and especially our kiddos that also have oral motor difficulties, it's hard for them to be around those foods. It's hard for them to manipulate food. So we have to make it engaging and fun for them. So make that food a toy. In speech therapy, we do a lot of play and a lot of imaginative play and pretend play. And that's how we work on language. That's how we work on feeding as well. So, a cantaloupe might turn into just a ball, right? The kid won't even look at it. Well, does it bounce? Can we roll it? Oh, wow. Now we've made 2 eyeballs. Now we're touching it to our face. Okay. The same goes with broccoli. It can be a tree. Next thing you know, my Cheerios underneath the tree. Oh, let's smell it. Does the tree smell today? Oh, it's raining. And now we have sauce on our tree. Next thing you know, we're mixing textures. It's kind of magical when you kind of take down all of those barriers and all of that pressure to the way we think about food as adults. It's kind of like anything else, right? When you kind of put yourself in a kid's shoes and look at food as they might and make it more appealing to them, it really is amazing the things that you can get them to do with it. So we want to think that it's okay to make a mess. It's okay to play with food, especially like Angela said, maybe separating those therapy meals. That's when you're really going to get down and dirty with the food. Maybe you take it outside. Maybe you take it on your patio, right? Versus when you're going to go ahead and focus on that nutrition. So oral motor, of course, this is an area that I love to hone in on. And a lot of our kids, they're very sneaky. They're very tricky. They'll fool you. They'll make you think they don't have difficulty chewing and swallowing, but really they do, right? So there's some different activities that we can do with kids to work on those oral motor skills, because again, it's hard and they don't want to practice. So we need to practice these skills with foods. It doesn't do a lot of good, and even research tells us that, to practice, different motor movements and strengthening without the foods there. We want to make sure we have food involved because that helps their brain connect the dots, right? Oh, I'm doing this motor movement. I'm strengthening, my cheeks and my lips and my tongue for the purpose of eating, right? Or for the purpose of speech production. So we can do this by having fun activities for them. So one that I love to do is, a lot of our kiddos love Cheerios. Okay. A lot of them, it's a safe food. They love a Cheerio. They love a goldfish, but they might have a tough time actually chewing. So they might just mash it, right? They might take that Cheerio, put it on their tongue and do this. And you just see the front of their jaw moving, but they're not crunching, right? And doing a rotary chew. So that could be for a variety of reasons. We would have to assess your child to honestly know what that is and to give you, more detailed tips. But a tip for kids that we know that do have difficulty with tongue, what we call lateralization, which is essentially moving your food from the front of your tongue to your back molars to chew, you have to do that. So next time you take a bite of something, think about what your tongue's doing. It's moving that food from your tongue, that initial placement, to your teeth, your molars, or you're tearing a piece of meat with these teeth, and then you're moving it with your tongue to your molars to grind it up and then take it to the back of your throat and then ultimately open up your throat and swallow. So we want to teach these kids fun ways to work on those tongue movements. So putting a Cheerio at the front of their mouth and moving it back to your molars. So I'll do it with a kid. I'll say, watch me. Boop. Boop, and we'll use a mirror and we'll move it to the back of our molars, and we'll just practice doing that. And then it's a food they like so they can chew and swallow. The same thing that you'll notice with the sucker. We have all kinds of fancy tools that we can use in our clinic, like this picture right here that helps hold the sucker in place, but you don't have to have that. At home, you can simply hold the sucker, the blow pop, whatever you have, and help the kid, hold it to the corner of their mouth. Let's touch it. Let's touch it. Come to this side. Let's lick it. Maybe you're going to touch behind the top of their teeth for that tongue elevation. A lot of our kids can't elevate their tongue. Maybe there's a tongue tie. Maybe it's just that weakness or that range of motion difficulty. So that's another activity. Even protrusion. So protrusion is just sticking your tongue out far enough to kind of take the foods in. With the lollipop, we can work on just sticking your tongue out to lick the lollipop. I have a lot of kids that really have a hard time with that. And it's a skill that you learn early on, but without that skill, you're most definitely going to have trouble bringing in a variety of foods and chewing them. Even lip closure. So keeping your lips closed so that you can properly chew. We can use a straw for that, right? She's blowing, this little precious little girl is blowing bubbles with a straw in a cup. That is working on her lip closure. The Twizzler or the fruit by the foot. I don't want to give a specific label, but you see it over here. Somebody help me out. What else would you call that?
Like a licorice.
A licorice, yes. A licorice, but let's be real. A lot of kids don't like licorice, so they usually like fruit by the foot,
Yeah.
Peels. This is a great, sorry, the words are just not there, but this is a great tool to work on those tongue movements and lip closure, because if you're working on different sides of the mouth and you have to pull it in with your tongue, you kind of have to hold it in on the side of your mouth with your teeth and then keep pulling, right? And then break off a bite. That's working all those muscles. So again, there's so many creative ways that you can use to work on the oral motor skills, especially if your kiddo is not chewing, is not closing their lips, really doesn't have those motor movements to safely take in foods. And that's number one thing, right? So that oral motor assessment that Shayna mentioned earlier is huge. You have to have a thorough oral motor assessment so that we can determine what is safe for you to do with your child at home. So again, these are some ideas, but every child's different. We highly encourage you. I know you guys had some questions about some of these activities. It's really going to be dependent on what is doable for your child, what's cleared by a medical professional as well as a therapist to do. But these are definitely ideas if your child is able to do some of those movements, of ways you can work on oral motor skills and make it really fun. I love these pictures, but I'll be very honest with you, I can't make any of these. So these are goals, right? But don't feel like as a parent that you have to make all of these gorgeous creations with the food, because I'll tell you, in my therapy, I make a lot of smiley faces, frowny faces, people. I'll make a snowman. I might make a little pond with my marinara sauce, and then our little friends, which are maybe the noodles, that are snakes, have to slither over and then they go swimming and they do a cannonball. So it doesn't have to be as elaborate as this, but food sculptures and pictures are huge. So many of our kids get so motivated when we make things out of our food. So even just a rainbow pizza or making a snowman out of rice balls. I actually have a little girl that I work with that she likes her rice served in balls. So her mom brings sticky rice in balls. And so I will start out by maybe making a snowman or building a tower, and then it crashes, and all of a sudden it crashed just a little bit into a little bit of marinara sauce. So she has to touch that little snowball. The next thing you know, the marinara sauce is on her hand, but we're okay. We're fine, because we can just, let's smell it. Let's paint our snowman. Right? So you're getting really creative with what you're doing with the food, so that you're just essentially exposing your child to these foods and playing with them without them even knowing that they're doing it. Right? And then it becomes safer to them. I love the turkey. That's amazing for Thanksgiving. So just getting creative, just, using what you have at home, the fruits, even having your child just helping you prep might be the best thing for them. So again, no expectation to put it in their mouth, just prep. Having children be a part of that prep and creating things with the foods is a great way to make them feel safe around foods. So I have a lot of kids that I work with that all I work on with the family is having them help prep the meals, have their own little bowls, their own little section on the counter. They make their own little animals. They make their own little creations. They maybe help put the vegetables in a bowl. Maybe they help put the fruits on the sticks to make these creations. And that's our expectation. And it's so great to help them feel a part of it. So especially with Thanksgiving coming up, this is huge. Have your child be a part of that prep, and don't be afraid to be silly and do fun things with the foods. And then, of course, the oral sensory explanation. So we want to start with what's safe for your child. So like Angela, Shana, and Nicole have said, some kids, it's simply just having the food in the room. I have worked with so many kids that have had major meltdowns just from a new food being, on a mat at a table next to them. So all we did was make that food walk into the room and do something silly, and they had to tolerate it for a second, and that's it. And then you build on that, right? So your child, we want to start from kind of the outward environment in, if you think about it that way. So tolerating the food in the room, then maybe they slightly touch it. Maybe they touch it first with a fork, then they touch it with their finger, then it maybe touches their arm, then maybe it touches their, cheek, then it goes to their lips, then their tongue and their teeth. And the next thing you know, they're taking a little mouse bite, as we call it, like a little baby tiny nibble like a mouse. Then maybe they're taking more of a big bite like a turtle, or like a lion or a dinosaur, whatever's motivating to them. And I will even show them pictures. I have kiddos that I work with that I will show them pictures. And now that's what they'll tell me is, show me a picture of a turtle eating an apple. Great. Google turtle eating an apple. Look, there's a turtle taking a giant bite. And next thing you know, they're taking a giant bite, right? I've got some kids that love Peppa Pig. Let's use Peppa. Right? So maybe during a meal that's a therapy meal and it's not during that time where we're wanting that nutrition, let's look at Peppa eating all the Thanksgiving foods. That's awesome. And then we'll go and prep our Thanksgiving foods. Maybe we'll pick a few new things to just touch with our hands, play with, explore. So we really want to make sure that we are realizing that our kids are, food is huge for our sensory system, and our OTs can really speak to this. It's the smells, it's visually what we see, it's putting it in our mouths, it's the taste. There's so many things, and especially around Thanksgiving, it's a lot of smells, a lot of textures, a lot of people eating all these foods that I've never seen. So we just want to be very mindful of that and kind of meet our kids where they are and guide them through those steps of exploration. And follow their lead in that and make it as fun and engaging as possible.
So we know that we have a lot of older kids as well who have challenges with food exploration. So we wanted to provide some options for them as well, because the approach is different, right? Like when we have kids, depending on their language skills, their understanding of the activities, they're not going to want to take the little dinosaurs and play around in the buckets, right? But we do want to make sure that we're giving them the same opportunities to get exposed to foods, to interact with foods and all those type of things. So first off, becoming a food scientist, learning how foods change, like the qualities of them. So when I blend a food, when I cook a food, when I toast a food, when I heat it up, all those things, what happens to cheese? Like cheese is a perfect example, right? It can be cold from the fridge. It can be melted from the oven. It can be soft and squishy when it sits out a little bit. All of those different things can happen. You can slice it or shred it. You can do big cubes of cheese, all those different things. Fruit is another one that can come in lots of different forms. Take the kids shopping. I'm a big advocate for this anyway now, especially, obviously COVID is a real, thing right now. So people are not going out all the time, but now that we're kind of getting back out there, having the kids in the store and seeing all the foods, having them help get the foods and putting them in the baskets. You hold the plastic bag, they count out the 5 apples, or you send them to do that. You have them help. Okay, let's find these things. It helps them work on skills outside of that, not just food, but it also really gives them exposure just being in the whole entire section with all the fruits and fruits and veggies and all those things. They're all there. They're seeing all of it. And then on those opportunities, they might see something and come across something and be like, I wonder what that food is. And that's a great chance to add that into the basket. Or, hey, today when we go shopping, the goal is, you eat Teddy Grahams. Let's go find something like a Teddy Graham that we can take home. And that's going to be our food that we learn about this week. Taking them to see all those different things, because a lot of times they don't even know what all is out there. I like to go through talking about food properties with kids. This is a big thing as soon as they start understanding this receptively, is what are foods like? What do they smell like? What are the similarities with those kinds of things? What do they taste like? Are they salty? Are they sweet? Are they sour? Are they bitter? Because if I can have an idea of what that food is, I can compare it to something else. So when I tell a kid, well, that strawberry is kind of sweet, like that really ripe raspberry you had over here, they're gonna be like, well, I like sweet things. It was cold. It was kind of squishy when I bit it. Those foods are similar. If I like strawberries, maybe I'm more likely to go here, because cognitively I can understand those foods have a better, like that quality. Same thing with crunchy foods. When I have kids, it's like, okay, let's explore it. What happens when I bite it? They might not be ready to go straight to a cold carrot, but they could do something like a dehydrated carrot because it's crunchy like my chips. But I do know eventually, like I can maybe get to a shredded, like those sliced raw carrot chips, and I can bite them the same way. I can crunch them the same way. But when I know what to expect as well, there's less trouble once they've received the food. Cooking together, I love cooking. I mean, OT is go team. We love that. Anyway, it's a huge part of the ADL piece, but it also allows you to see how the food changes. It allows them to be involved with it, and they can use whatever they need to throughout that. So if you have kids that are having a hard time with eating the food, again, they're going to get the exposure throughout all of those steps. They can use whatever tools they need. Maybe they need to use the spoon. Maybe they're not ready to put all those in. I don't want to touch the chocolate chips to put them in the dough. I need to wear some gloves when I mush together the batter, but I can be here with you at getting more exposure to all those pieces. And then having a support food at the table. So I use this with some of my older kids, is the idea of like, okay, it's not so much a first then, it's if you try that food and it's hard for your body, let's have a drink available. Let's have a food available that's manageable. This isn't like we only keep your preferred food. It's not giving them the safe food like we've talked about earlier in the presentation. It's something like, okay, I took a bite of that new food. I'm going to come back and do a Dorito because that flavor helps me work through it. That blueberry was really hard. It was too sour. I'm going to take a sip of my favorite apple juice to work through it. They can understand, and that's, again, this is based on the cognitive level for the kids. We can't use this at all ages. With little guys, they don't care. Some of our little tinies, they don't care. They just see that and it looks aversive to them. But yeah, helping them have something to move on from a flavor and practicing that ahead of time. So I'll do this before I ever get to the non-preferred foods. We teach these skills, and across everything we've talked about, we teach this before we start introducing the really challenging foods. So I know how to discard my food. I know how to tell you. And one thing I think we even need to talk about in this presentation is like that speech component too. I know Highland can talk about is how do we appropriately dismiss this food? And then behaviorally, how do we appropriately dismiss this food and communicate with my family? This is too hard. I don't know what to do here. I'm not interested. I don't know what's next. Are you putting more things on my plate? So we have to teach kids some of those things, and being able, like, that's where the support food comes in, is like, you know what, I need a bite of this. That was a lot. I need an extra bite. Okay. You know, they're hanging with you. And that's the big thing that really is a win of that. And then with our older kids too, obviously, like, we want to increase the amount of time now that their attention's higher. So all of these things that we've kind of talked about here require them to engage for longer periods of time. And they, whereas little guys, it might be challenging. The little guys might be able to go to the store with you and like throw some foods in. But, you know, when we're talking about like our kids anywhere from like 5 and up, even up into our teen years, they can participate in these things a lot differently. So one of the big things that we always like to really mention is the reason why any of this matters. At the end of the day, it's obviously really hard in the family dynamics. We know that it makes day-to-day living really challenging. But if not addressed, if we've put these kids in these picky eater, problem eater categories of like, that's where they're at, these are some of the risks that end up coming up long-term or short-term. Is they have trouble gaining weight. That makes it really hard when kids like get sick, right? Then they don't have the body weight to support themselves. They may need to get a G-tube placed to get their nutrition because they've restricted so heavily, they're not getting their needs met. We go through the oral motor component and the swallowing piece because they're at risk for aspiration pneumonia. And that's a whole other medical side and swallowing difficulties. They might not be getting the nutrients they need, so they end up with deficiencies. Food jags are a big one that we've touched on a lot. And not like having foods in their diet, they eat them so much that then they eliminate them. And then what they had, this 10 foods are now down to 4 or 5. That's when it gets really scary. And that's when they are at risk for things like a G-tube placement, right? Because we're trying to feed them and get those calories. And then what happens when we get down to 2 foods? We're in a lot of trouble. Difficulty at mealtime and in social situations. So they can't even go to the parties. They can't go to do, the camps. They can't at lunchtime at school. It's so hard. All of those things become so stressful for them. And it looks like they're having problems behaviorally in those situations, but really it's a lot of it to do with the meals. And then the older kids get, the harder this gets because cognitively it gets trickier and trickier. So they go through ages where their brains don't understand it. When they're itty bitty, when they're tiny, it's like, okay, we feed them, they get exposed to whatever we give them. And then all of a sudden they say, oh no, I can't handle that anymore. I am in charge of my own body. And then they go through another page, like, I can accept that. So as we go through that, it goes all the way up through the teenage years. It becomes harder and the way you address it has to be different. All right. So a feeding snapshot of just everything that we've kind of gone over. These are like the big take home things is try to match foods to those that your child's kind of eating already. So we've talked about like, that's the quality of the food visually, the textures, all those kinds of things. Let's meet them where they're at. Try to build those bridges first to what they're already consuming. Try to work from the skills that they already have right now. Having them, getting a safe plate for them, making sure that they have something there so they want to come to the table, establishing these mealtime routines, expectations, consequences, all those type of things ahead of time with kids so that they know. Eating with your kid, be a model for them or have somebody else. If you're not able to, for dietary restrictions, for allergy restrictions, have somebody model those type of things for them. Even watching a cooking channel, have them see other people involved in that. Explore textures in different ways that there isn't the expectation to eat. And then just playing with the food and not being afraid to let them get messy. I mean, it's 2 things, right? We can either put them into something so that they're covered, we're not worried they get messy, or just our little kids, just take them out, have them be in their diaper or their undies. If they get covered, we just throw it in the washer and we're done. I think we're close to the end.
All right, everybody. Thank you so much. I know that was a very long presentation, but we are all so passionate about helping our kiddos and doing the best that we can to help your kiddos, especially with this multidisciplinary approach. It's so important that we all collaborate to do the best we can to provide you with tips and tricks and ideas in terms of next steps for assessment. So we can take this time now to answer the questions. There are a few questions that are in the chat box. I will start with one question if you guys are okay with that. An anonymous attendee said that my 2-year, 9-month-old child still eats pureed foods. He tries most of the food though on his tongue tip, but is scared to put to any solid foods in his mouth. If I put small piece of solid food inside his mouth playfully, he just uses his tongue to wipe it out on his shirt. I would appreciate if you have a suggestion. So for this kiddo, it's without, again, assessing your child, seeing your child. My first thought is that if he's allowing you to put it on his tongue, he's interested in it, right? So he's interested maybe in this food and learning more about it. So it could be a variety of things. It could be that we need to work on some tongue movements and maybe getting him to use his tongue a little bit more with his feeding. It could also be that maybe we pull back on where we're placing the food. So maybe we start by just getting him to give that piece of food a kiss, right? And maybe he just smells the food and then, oh, we give it a kiss. Mwah! Mwah. Oh, wow. That seemed a little sweet, huh? Let's maybe give it another kiss. Mwah. Right? Maybe then the next thing we do is we get him to just touch the food with his tongue. So let's just lick it like a lollipop, right? Like a little lizard lick. I call them lizard licks. Let's lick it like a lizard. And you seem so silly doing it, but just having him lick the food. Then when he feels a little bit more comfortable, maybe we put it in our mouth and expect him to chew it. However, if it is more of that oral motor difficulty, so it's likely that since he is only eating those pureed foods that he does have some oral motor difficulties, we want to maybe work on some of the chewing and the tongue movement. So even helping your child, move a little bit of peanut butter or a little bit of that pureed food or something where he can lick it and move it back to his teeth. And I want to see it on your teeth. Show me that food on your teeth back here, to work on those lateralizations of those movements. We have some tools that we use in the clinic that are really helpful for that, to start working on chewing. So another thing you can do is you can dip maybe a stick, or you can dip a spoon, or you can dip something that's like a chewy tube, if your child has any chewy tubes, into some foods, into the puree, and start working on taking that food and moving his tongue back to his molars. So you literally would take it and start at the tip and slide it back, because your tongue, there's a reflex where your tongue will naturally start to move when you start to, I guess, train it to move back to those molars. And then you can try to get your child to start biting as if they're chewing. So dipping it in that yogurt or dipping it in that puree, guiding that tongue back and working on those chewing movements. Those are two of my tips. But again, it would be very dependent upon seeing your child and what's exactly going on there.
I think what I'm definitely hearing too is that the importance of modeling, showing your child, if they don't know what to do with the food, sometimes showing them what to do, which means all the food that you're giving your child, you're giving yourself too. And if that's not an option, kind of to Shayna's point too, maybe we can sit in front of a mirror, or maybe we can bring a mirror to your child so they can see what they're doing and they're getting that visual feedback. Sometimes, exactly to Highland's point, if your child has not experienced the full breadth of the different textures and the types of foods that they can eat or should be eating soon, they don't know what to do in their mouth. So we need to isolate those movements and teach them those motor sequences so they can do that successfully. But a really big, important function of that is also opportunities to model when you can. So if anything that I have my clients do, I do with them too. And very often we might be eating foods I don't like. Bananas being a big one that I'm not a fan of. I have my own food aversions as well. And that tends to be a common food item, but I'm right there with them and trying it as best as I can. So within your reasonability, I would definitely recommend that.
Any of those motor movements as well, like Angela said. And that's why a mirror is so great and can be so fun, because we're watching each other do these silly movements and you're doing it with them. So a lot of times I have parents tell me, so my child wants my plate and my food, but they won't eat anything on their plate, but it's the same thing. I'm like, great, let's switch. That's why, like to Angela's point, put the same foods on your plate, eat the same foods the best that you can, so that they're seeing, hey, it's safe, it's okay. And this is what I'm doing with the food. I'm teaching you how to manipulate this food. That's huge.
All right. So I know we have another question as well that came in. It looks like the question was, my kid has a genetic brain disorder and we have been working over the years with feeding therapy. She's gotten so much better with eating and chewing. She's still very picky and eating different foods. She's not picky in terms of textures or presentation and such. She mostly prefers carbs, as do so many of our kids, but she will eat meat and veggies on occasion, but not preferred. Her main issue is I never know when she's hungry versus when she's full, and she doesn't feel thirsty. She will eat mostly anything if I bribe her. Getting enough liquid intake is a lot of pushing her to drink during the day, and she never really grabs a drink to drink it herself. Any tips on the interoception issue? Which we didn't touch a lot about on, and I'm glad somebody asked that. Interoception is a factor within all of this. We talk about the different senses in the body. And this is a whole other, area within OT that everybody kind of gets impacted with, but it's body sense. And with feeding, that means thirst and hunger cycles as well. Some kids get full very quickly. They think their body's full, but a lot of our kids seem like they have an endless pit that they can just keep swallowing things down all the time. This is a tricky question to answer because obviously without the age of the little guy, or how old she is, like that plays a factor as well. And then depending on the disorder going on, like some of those things do play a factor in the body's receptors too. So when we're teaching these kinds of things, we will look at providing compensatory skills as well if they understand. So recognizing that, and then we've talked about routine and things like that. So putting kids on a schedule with their foods so that they get a chance to register normal appetite times. So grazing is definitely not supportive in this area. Letting kids free feed does not help that. So having them go on, like we look at like having them eat breakfast within somewhere between 30 minutes to an hour of when they wake up. Snack type happens anywhere from 2 to 3 hours after that. And then they do another meal sometime after that. And that depends on the kid. In general, kids don't always eat 3 meals a day like adults do. Some of them have 2 really big meals and 3 really bigger snacks. So you kind of have to figure out like how many calories sometimes you're presenting. But yeah, breaking it up so that they go into those periods and then not letting them have things like fruit juices or candies and things in between. Those fill the kids up. They're empty calories, or even other kinds of drinks. Like if we're offering them something like chocolate milk in between their meals, they might not have a chance to feel hungry aside from the interoception. It might just be like they never actually have a chance to feel hungry too. So we want to make sure we address that on top. But yeah, putting them on a schedule is a big thing, talking about it as well, helping them understand like, when I eat these foods, when I'm done, what does that feel like for my body? My tummy feels full. I feel like I can, like when things go in, I don't feel like I need any more to drink. Putting them on a schedule or like making sure they have a water bottle, like a couple, if they're going to school, let's fill up 2 water bottles for them. And like, that they have those sitting out there. Those things are readily available throughout the day, whether you're at home or at school, to compensate for that so that it's there. Like if they're on their desk at school, we have this bottle. We could, for older kids, we even put like, the time on that, like, let's try by 9 o'clock, we have this much of it done, just so that there's an awareness of like how much they're actually taking in, but it depends on the age. So they do need a lot of support from parents when they're little, to recognize these things. I've got to say, like interoception, I feel like really doesn't come into play super heavily for kids from all sides until like they're a little bit older anyway, 5 or 6, that you can kind of really get them there. Our little guys will be like, I'm done eating sometimes, but look at the foods too that they're eating. So if they're choosing those carby foods, they don't hold them over very long. So if they're eating a lot of things, it's because maybe they're not getting those calorie dense foods either that hold them over. Or if they're eating really heavy foods, again, they may feel full all the time. So there's other things outside of just the interoception that we would have to kind of really look at too. But finding compensatory strategies is one option as well, to just help them build awareness and then creating an environment for them that's supportive of making sure they have enough calories, enough times during the day to support them, and their little brain function. I'm going to see if there's some more questions.
I see there is another question. An anonymous attendee asked, how can we treat oral motor difficulties in eating at home? Highland, do you want to start with this one?
Sure. So I would definitely go back and look at that slide that I presented on those oral motor activities. Again, it would be, I would definitely need to see the kiddo to determine what types of oral motor challenges your child is having. So is it involving the tongue movements? Is it the lip closure? Is it maybe the strength and weakness of the cheeks? Is it the chewing? So without knowing that specifically, that's a little bit tricky for me to give you detailed answers. But in general, I would make it fun and I would do some activities kind of like on this slide. So if it's lip closure, if your child's having difficulty keeping their lips closed and keeping food in their mouth, you can do activities such as blowing bubbles with that chocolate milk, like Shayna said, with the straw. That's going to work on lip closure. You can work on tongue movements by taking that Cheerio on the end of your tongue and moving it to the back, right? The same with the lollipops. We can work on, a lot of parents I know don't like to use candy. And I know, and a lot of these foods that we've talked about tonight, parents are like, those are bad foods. We get it. We want your kids. Our goal is to eat those healthy foods. But it's kind of like with other things with our children, like play. We have to use what's motivating to them to get them engaged and have them feel safe to build up to those foods that are a little bit scarier. It's the same with the oral motor movements. So using a lollipop to work on those tongue movements. So having your child, putting the lollipop over here and let's touch it with our tongue and lick it as many times as we can. Let's put some peanut butter maybe on the roof of our mouth behind our teeth and just push it off with our tongue, right? Let's try to keep our jaw open and push that off with our tongue. Let's maybe roll this fruit by the foot in the best we can with our tongue and our jaws and our teeth, and we're closing our lips. So there's all different ways that we can work on those oral motor movements. Always try to pair it with a food item. So if you're working on chewing, you want to maybe dip a chewy tube, like I said, in that yogurt and chew on that first. Maybe you want to dip a sucker in and kind of work on that crunching a little bit. So you want to keep it safe. Every child's different with what is considered safe based on what they can manipulate and control, but making it fun. Another thing you can do is a toothbrush, an electric toothbrush. Some of our kids hate toothbrushing, which is a whole nother presentation for another day. Some of our kids are really motivated by their Mickey Mouse toothbrush or whatever it is that spins, right? Use that to work on those motor movements. So let's work on, brushing the sides of our tongue, bringing our tongue back to touch our teeth. Let's work on like brushing our lips to wake those up, right? Then we want to give it a kiss, mwah, to work on that pucker, mwah, mwah, mwah. That's oral motor. So there's so many different ways, but those are some suggestions to get started without fully knowing your child and where they are and doing a full assessment.
All right, I think we had just one more question on here. It was about my kids and I have been living with additional stress for 3 years. It has been difficult to create structured meal times or even create time for a calm family meal. My 8-year-old's problem eating sounds like the ASD type sensitivity you described, and I don't know how to balance any kind of feeding support with everything else. Do you have any suggestions for how to balance work on feeding problems with addressing other family challenges? So this comes up a lot. I mean, outside of everything, like family dynamics do play a big role with this. And I mean, we even have kids that are in separate households that are dealing with multiple caregivers providing mealtime to them. So we hear this often. And so one of the first things we'll say is, give yourself a little bit of grace on all of these things because there's a lot on the plate. We want to make sure first and foremost, the kiddo is getting the food they need. They're getting the nutrition they need. And let's take small steps within what's manageable. So, within this, we like to find out like, what's the family schedule like too, because family mealtime, like we've talked about, we have therapy meals and then we have, nutritional, like let's let them get their meals so they can needs met. When is a time that maybe this can happen? If we take away the pressure of this happening every day, or even every other day, maybe we just shoot for the weekend when everybody's home, we have them all together. There's no crazy routines and after school sports and all those kinds of things. Take that pressure off the table because nobody needs that. Let's try and pick maybe lunchtime on a Saturday. That's the time that we deal first. We start looking at those things first, is one time a week. And then start building those strategies early on what to do. So if you have a kiddo, and I'm trying to understand the question in terms of if it's that they have challenges hearing eating sounds or when they're eating their own foods, there's lots of different things, or maybe the textures of foods. But with any of those things, like we have different strategies of, we'll play gentle music when other people are eating, if it's hard for the kiddo to be around. We do that in my household. My husband has misophonia. He can't handle hearing anybody eat, including me. So we always have something on in the background. It's been hugely helpful. And, so taking away, because basically your body has to discriminate that sound. So it drowns it out a little bit. Picking something calming though, preferably. Or if it becomes too hard, sometimes we'll even have kids at mealtime that do use headphones because they can't handle it, or giving them the opportunity to eat for a period of time away from the other kids and then coming back. If they need to practice with you. We want to try to have the family dynamic all together though, if we can. So it is tricky on this front. We need a little bit more information, that type of thing, but even just setting expectations for how long they're going to be at the table too, initially going back to using timers and all those kind of pieces to support them.
And I think someone also asked about how to balance feeding therapy and other stress needs at home. This might be tied into that same question, Shayna, but an option is telehealth. So we do a lot of telehealth feeding and parent coaching. We recognize that during this time, especially, stress is very high. So on top of COVID, on top of going back to school, not being in school, masks, family dynamics, there's so many stressors right now. And that's another reason why we offer telehealth services even for feeding. So it could be something, that's stressful for you to try to get your child into a clinic to do feeding, and that's not something you can handle. So telehealth is an option for that. So us being able to zoom in, see your family dynamics, see what's happening during those meal times, and give you some tips and tricks of ways to work on that can also be really helpful. And it's been really helpful for a lot of our families, just making those kind of environmental tweaks and helping with ideas of how to get your child to the table, introducing new foods during those times can be super helpful. So that's just another suggestion of something that you could do to kind of help with that stress.
And I think just our final question, which might hopefully round out a few people's questions, is how to get started if you're not currently seeing, you're not currently in ABA or speech or OT. How can somebody get started with feeding therapy if, maybe after watching this presentation, they realize that they could use some help?
I can feel that. First thing, if you've liked what you've heard and you're looking for more support in this way, give us a call. We can help you. We have we have a family success team that answers the phone during business hours and can help you navigate this process. We know all too well as clinicians, and some of us are parents as well, that the therapy process and navigating what that means and what do I need to give to get ABA started, and what is OT and what does it mean to get speech therapy, and I don't understand telehealth. We have a team in place that can help you with those answers. Give us a call, email us, find us. There's a web inquiry option on our website too. Let us know, reach out to us. We're very happy to help you navigate this process. We know it's a tricky one, and that's why we're here to help. What we can then determine as a team, if we think that it's that the needs of your child might be better suited for one service or all three or two services, or however we can support that. It's also specific depending upon your location too. So wherever you are, our family success team can help you receive the services that we provide in your neighborhood, in your location, what you're looking for. So that would be certainly my suggestion, is give us a call, and we can help you navigate that. Another big piece of that puzzle is speak to your physician, speak to the pediatrician. That is the first step into getting access to a lot of these services. Explaining your concerns, utilizing some of the terms that we may have said in this webinar to help give you the tool in your tool belt to be able to go into that physician's office and say, these are the things that my child's experiencing. This isn't typical. I need support. And sometimes we just need to know what to say or what language to use or what triggers that referral to come and see us or other professionals in your area. So I would definitely start in those two places. I don't know if anybody else has anything else to add.
Thank you. You nailed it. You nailed it.
We're all waiting here to help your kids. Please send them to us. We love doing feeding therapy as a group, and we've seen a lot of kiddos change drastically, in these types of programs. So don't feel afraid. Just reach out, and our teams are amazing at getting you guys exactly where you need to be.
And that's I think a perfect way to end the presentation tonight. I appreciate, we've had a lot of really great questions. So much information, and we were getting a lot of thank yous in the question and chat boxes here too. So thanks everyone for hanging in with us tonight. I know this is a long presentation, but there's so much information shared. Like I said, this is recorded. I'll send out the link so you can refer back to this information and rewatch it. I mean, there's so much content here that hopefully will continue to help you and your family. And definitely contact us with any other questions or anything else. We will do another webinar in December. I'll be setting that up, and I'll send that link out to you as well for our what are we calling it? Our ABA survival guide for the holidays. So thank you again for joining us this evening. We will sign off, and we will hope to see you next time or to hear from you. Thank you so much.
Thank you.
Thank you so much.